lot of our patients that do ECT, we do about 70 to 80 ECT, electric convulsive therapy, for patients. And a lot of times they miss their appointments, and it's important once you're in the system, when you're doing ECT, to continually do those. And they live too far away to drive, so there's no transportation for them. So that does help.
But they can't drive home after treatment.
Even
if they have the car.
That's right. It is for a little while.
Right.
We keep them there for a while, but they shouldn't go and drive home. And we also, there's one other, component to this which we haven't talked about is the geriatric psych population. If there was anyone here from nursing homes, the nursing homes are at a huge. They have a huge problem with demented patients who become violent. And it is actually outside of their scope of practice to manage those patients who are actually hitting other patients or staff, and they are less staffed than obviously a hospital type setting would be. So we do take, we take anybody that comes in the door, as I said, so we could have a 21-year-old substance abuse, primarily mental health, suicidal patient, along with an 85-year-old demented patient from a nursing home, psychotic, right? So we're trying to manage their medications and get their behaviors to the place where the nursing home can then take them back and manage them. And it is really, you can imagine that different scope and all in between of what it must be like in a small environment trying to manage all those people all at once. But the geriatric population, it's a huge need. The nursing homes are just dealing with it right now. They're just managing the best as they can. They put extra staff on and all that. But really what that population needs is a short-term, typically 14-day length of stay in a geriatric psych unit where a psychiatrist is managing their psychotropic medications, and they get kind of a break from the nursing home, and their dementia doesn't ever go away. It doesn't get better, but their behaviors get better, and then they go back to the nursing home. So that is another need. I think if there's someone from the nursing home community here, they would say for sure we would need that.
Hi, I'm Randy Reed, Program Director for Winchester Medical Center for Behavioral Health, and also for the Valley Health System, 2 hospitals in West Virginia. I'm new to the area. I've spent the last 15 years in Baltimore and just moved to Winchester about a month ago. So I'm just learning my own hospital and learning about the region. That's why I was taking so many notes here listening to these guys. And just finding out myself what the gaps are in service from talking to therapists and talking to people in the community and what I've observed. We have a 26-bed inpatient unit, a general adult unit, with an array of diagnoses. Generally, patients come in with schizophrenia or bipolar disorder or major depression. And many of them also have accompanying substance abuse issues. We do provide detox on the psychiatric unit. We can't admit somebody strictly for detox. They have to have a primary psychiatric diagnosis. But if they need detox for alcohol, benzos, heroin, we do provide that. We also provide ECT, inpatient and outpatient. And we have a 24-hour, of course, crisis assessment service in our emergency department. And then we have a small outpatient clinic located just down the street from the hospital on Amherst Street in Winchester that provides strictly medication management, no therapy. We have 3 psychiatrists there and no therapists, unfortunately, so it's just med management that's provided. We are looking to expand. One of my mandates coming in is to look at the Valley Health System and see where other services are needed and where there's interest. So we are looking at adding inpatient beds, and we're looking at adding outpatient services to those 6 hospitals in the Valley Health System, including Winchester Medical. We're talking about adding medical psychiatric beds for patients who come in with acute medical issues, but also have acute psychiatric issues. We're looking at adding geriatric beds. We're talking about child and adolescent beds, and then we're talking about an array of outpatient services in the different hospitals. We're actually going to have a large presentation on February 19th at the hospital, and the CEOs from the other hospitals in the Valley Health System will be there. And I actually work for Diamond Healthcare. Winchester contracts with Diamond Healthcare to provide behavioral health services. So that presentation is going to be by Diamond to the Valley Health System on February 19th. So we'll know a lot more about the direction we're going to be moving in at that time. But we're definitely looking at expansion. All these guys are talking about the need, and definitely it's there. With respect to gaps in service, the biggest one that I've seen so far are, of course, services for the uninsured. About 25% of our patients admitted to Winchester Medical are self-pay patients. If they come in under a temporary detention order and they're committed to the hospital, we can send them, once they're discharged, to the local community services board, their array of services for medication management. If they come in voluntarily as a self-pay patient, we literally have no place to send them. There are no agencies out there to send them to. So we end up trying to find agencies that have United Way funding, that type of funding that will provide a service, or we give them information on free clinics for their medication. But that's the biggest gap that I've seen so far. What do we do with uninsured patients who come to us on a voluntary basis?
We're getting some of those in our Charlestown office and also in Rochester.
Yeah, it's very frustrating for our discharge planners and for our inpatient therapists as to what to do with these patients, because again, it adds to the, as Dan was pointing out, it adds to the recidivism rate, which is quite high with the recycling and the patients coming in and out using the emergency department for their care. Of course, I've also seen issues with transportation and with housing of patients too. Those are larger issues, but what's exciting to me is that the hospital is very, very interested in expanding services and adding services, and so I'm looking forward to being a part of that. Julie, take it.
One thing I just want to add that I've noticed is, when we're talking about folks when they're discharged and how there's the gap in time because of the waiting lists. I think if there were more case management and more treatment type positions in place, that there'd be that service to kind of guide and hold their hand until they can actually get to the more clinical level appointments that can really
Another aspect of that is in West Virginia, the medical assistance program does not recognize LPCs, and they do not reimburse other master's prepared people in the community outside of like a clinic setting like mine. So that when you consider the number of people that are going to be added to the medical assistance roles now, I think really looking at the restrictions the West Virginia Medicaid program places on therapy and treatment. In our agency, they cap, because we're an FQHC, for some reason they cap it at 10 visits. So that may be sufficient for some adults, but it is usually not. Given that the people on medical assistance under Medicare have the most complicated and difficult care, they actually need additional services to that. We're finding fewer and fewer places are offering therapy, and that really is because of the restrictions and the reimbursements for managed care being below cost, so that it's not a positive element in most business plans to provide that, yet it is the very thing that's needed for a lot of the people that need more than just medication.
I'd like to add two things to what's been said. Eastridge is in an interesting position because for the first time we have a full complement of licensed therapists. Our problem is we have no more space for therapists. The second thing, we talked about access. We have experimented with, for the last year and a half, with open clinic. We have a day a week where you come in, and it's a waiting game. It's not perfect because people could sit for hours, but anyone who comes in that day will see someone. They will get into the system. They may or may not see the doctor, depending on how backed up the doctors get, but they will see someone, a case manager, a therapist, or whatever. When I get to the point of having additional psychiatric time, I'm going to expand that open clinic concept to 5 days a week. Then when Dan or Jeannie has someone, we can see them They can show up, they can be seen, they can get into the system. Now the problem is down the road. When is the next appointment? They're in the system, but when is the next appointment?
Mr. Reed, did you want to?
That's what I say. Julie Alexander is our outreach coordinator. She's been here for a couple of years, and she's talking a lot about the region. So again, I'm just learning. But again, what I would like to emphasize to the legislators is uninsured. What do we do with the uninsured? Coming from Maryland, Maryland has a system. They don't have community services boards, but they have community mental health centers, and they are mandated by the state to provide services to the uninsured. I don't see that happening here, and I was really surprised. I don't mean West Virginia, I'm talking about Virginia. There does not seem to be that mandate to provide services from the state or the localities to the uninsured. And so they're kind of left there hanging. So that's our largest area of frustration that I have observed so far.
West Virginia does have a charity care program for legislators. One of the problems is the eligibility requirements are so tight that it eliminates a lot of folks.
What was the requirement?
The requirements are income requirements, family size requirements. Many people don't meet those. The idea is good, but we're not able to bring in as many people because of the eligibility requirements.
I wanted to thank our panelists. We're going to open up, we have a little bit of time to open up for questions, and if the audience doesn't mind, I'd like to open it up to any of our legislators first, if they have questions. Ms. Woodmire?
Well, I just wonder if the 50 acres that WVU Hospital just bought in Jefferson County for a long-range plan, whether that long-range plan includes any facilities for this type of continual care. And should it?
I mean, I think it's not a bad idea. I haven't heard any discussions around. Arlene may actually know a little bit about any of that. Have you heard anything about those?
It is at the very initial stages of the strategic planning. It is in there. However, it actually will come to play. I'm not really sure. We're obviously in the very initial stages. So just to let you know, it is in that list.
Is that for inpatient or substance abuse or crisis
Very initial, as
stabilization?
far as I know, but we do have the land there, and the community needs to help us with the community health needs assessment came into play with the Baby Health is one of those.
We've been talking with Jefferson as well to do a intensive outpatient practice in that area. Space is an issue. It's actually would be a very financial viable. There's some benefits in a critical access hospital to do those kind of services. So that is something that we're talking about right now. But you know, it's a big system, and it takes a while for things to actually happen.
I was just going to make a few comments, maybe a question. Does Valley Health in its Virginia services accept West Virginia Medicaid?
Yes, I believe they do, yes.
And I think that one of the questions I had earlier was, is it usual or unusual state to state to have Medicaid not be accepted, Medicaid eligible patients not be accepted because facilities will not take the other state? For example, how many places in Maryland within 30 miles will accept West Virginia Medicaid?
I think most of the acute care inpatient facilities will that are around. They don't accept it for outpatient services. So there are those issues. And we accept Virginia Medicaid too, so those people seeking therapy come on up the road. However, I do think if there were at least a border county inclusion for outpatient services, it would really also help.
Let me make a comment about money and a comment about advocacy. In the big picture, obviously we are all